And welcome to our session here titled The Increased Risk Donor. So I think it's a very timely topic given the opioid crisis that we see in the province for the past 2 years. And here we're going to welcome Dr. Jag Gill to give this talk. Dr. Gill is an associate professor in the Division of Nephrology at the University of British Columbia. He is a transplant nephrologist based at St. Paul's Hospital in Vancouver and the medical director of data and quality at BC Transplant. He is also the Vice President of the Canadian Organ Replacement Register Board of Directors and a Michael Smith Scholar as well. Dr. Gill has numerous peer-reviewed publications and funding from CIHR, BC Transplant Research Foundations, and the Kidney Foundation Canada. So welcome, Jag.
Thanks very much, James. It's odd to get applause at the beginning. I feel like I'm done now. Thanks, everyone. Good afternoon. Thank you for attending the session. As James alluded to, this is something that is becoming a question, this issue of what do we do with increased risk, and specifically I'll be focusing on high infectious risk donors and what the implications of that are in terms of organ donation. And so we have an hour, I believe, in the session. I'm not going to talk for the entire hour because I'd like to leave a chunk of time for discussion and questions, and so I'll aim to keep this shorter rather than longer. So these are some I'm sure you saw some of these stats earlier today, looking at what's happened to deceased donation rates in British Columbia. And what we've got here is the number of deceased donors per million population, which is the standard metric by which we look at donation rates. And in blue, you've got what's happened in Canada over time. And there has been an increase in the country overall, a lot of it because of donors after cardiocirculatory death. But in British Columbia, we've seen a very steady rise and really have come from a place where a decade ago we had the lowest deceased donation rates in the country to now to a point where we've got the highest deceased donation rates in the country. Now, if we look at the trend, you can see that there's a couple major spikes there. So it has actually overall been a pretty steady increase in the number of deceased donors. But certainly in the last couple of years, there's been an additional spike. So if we look at what the impact of that has been on our patients, it's obviously been very positive. Our patients are having to wait shorter periods of time to get transplantation. And this is a graph looking at the median wait times in terms of dialysis exposure among patients that were transplanted over time. And you can see the median time in the last decade has dropped from about 70 months down to close to 30 months now. So a huge difference in terms of wait times for our patients. So as transplanters, we've been very pleased. We've been very happy about this. Now, the issue James alluded to, if we look at what's happened in terms of drug overdose deaths, we've all seen the news, we've all heard the horrific stories about what's happening with the opioid crisis. And you can see that this is from the BC Coroner Service looking at the number of deaths broken down, unnatural deaths, what they're calling, broken down by cause. And so you've got illicit drugs, homicide, suicide, prescription drugs, and that dark blue line that's shot up is the illicit drug associated unnatural deaths in BC. And if we look among those and you break those up into fentanyl-related or opioid crisis-related deaths and those that are not related to fentanyl, obviously the jump has been in fentanyl-related deaths. So this is clearly opioid crisis. And so this is 2015 to 2017 is where you're seeing this big spike. And if we go back to our deceased donation numbers and see what's happened between 2015 and 2017, it does mirror that to some extent. So, I think in terms of, we get asked the question, or BC Transplant gets asked the question a lot in terms of what has caused the increase in deceased donation rates. And I think it is important to recognize that probably the biggest contributor over the last decade has been the investment to increase resources within intensive care units so that every potential donor's family is being asked. That's a big difference than when it was 10 years ago. But if you look in the last year, there's no question that the opioid crisis has contributed to an increased number of potential donors that are out there, and therefore we're seeing a bit of a reflection of that in our donation numbers. So I thought we'd start with a few case scenarios, and I don't know how this is going to work. I don't know if does everybody have a capacity to say yes or no to answer these? Okay. Perfect. Well, if not, we'll go to show of hands. We'll go the old-fashioned way. So I've just got a couple case scenarios. So this is a deceased donor. There's an error in this. I'll just correct. It's a 54-year-old man who's a donor, a brain-dead donor was the old terminology. Now we call them neurological determination of death. Had a subarachnoid hemorrhage spontaneously. Kidney function is good. Creatinine is 87. The social history that was taken from the next of kin was that this individual was incarcerated. This is an older version, so I'll change this. It's not incarcerated in prison for 3 years, 4 years ago, but let's say was released from prison 8 months ago for the purpose of this case. But in terms of other sexual history, in terms of drug history, there's no known history of any high-risk behaviors that this person's aware of. So, is it number 1 and number 2, James? It is. So yes, number 1. Who would consider this person as a donor? Number 1. You can select. Okay. You got a show of hands. Okay. Good. So perfect. We'll come back to these cases later. Another case. This is a 24-year-old man who has a history of drug use, had an anoxic brain injury as a result of a drug overdose. It was fentanyl. Serum creatinine is 62 micromoles per liter. Obviously, no significant medical history whatsoever. The social history is that this person did use IV drugs, and we know that that use might have been in the past 2 weeks. The patient's been in the hospital for 8 days, and so the same question: who would consider this person to be a suitable deceased donor? So about the same numbers are saying. So the majority of you are either abstaining because you're not sure, or well, let me ask that question: how many people would not use this donor? Okay, so there's lots of abstention. Perfect. So we'll come back to that. Now, when we're thinking about donor-derived infections, that's what DDI stands for there. There's a number of obvious different pathogens that we're thinking of, and it goes beyond the common ones we think of. And so there's obviously viral considerations. There's hepatitis, there's HIV, there's things like West Nile virus, which are much less common but still have to be considered. There's bacterial infections. There are donors that have gram-positive or gram-negative cultures and are being treated for those. TB is obviously a consideration. There's parasitic infections, there's fungal infections. Prion, in terms of Creutzfeldt-Jakob or mad cow disease, is also a consideration. Again, very rare, but this is the gamut of infectious considerations that we need to take into account every time there's both a deceased or a live donor. And so in getting the social history from these individuals, we try to get a sense of this in detail. Now, obviously, when we're talking about living donation, our ability to get this history is much better because you're getting it from the individual themselves. In the context of deceased donation, you're getting this history from a next of kin, who may or may not be aware of the person's intimate life, and so that does limit our ability to really get these details. There's been a number of publications of transmitted infections from donors that have impacted recipients. And so this is a list of many of them. In 1985, there's a case of HIV, there's Hep C. As you can see, there have been West Nile virus cases, not very many, but there have been over the case of years, many cases reported where this is a reality and this is something we have to be concerned of with all deceased donor transplants. Now, how likely are these? These are generally rare events when you think about the number of transplants. This is looking at U.S. data, keeping in mind, in the U.S. you're doing close to 10,000 transplants a year. And so, you've got 160 reported events in the U.S. between 2005 and 2010. Having said that, we're not sure how complete that reporting process is. And in recent years, they've made huge efforts in the U.S. to really shore that up a little bit so that they've got more reliable reporting. But nonetheless, it is a pretty rare event, even though it's underreported to some extent. And importantly, this doesn't just pertain to organs. There's also tissue donation. The same considerations have to be thought of in those circumstances. There's been some media attention towards this. This was a New York Times article from a number of years ago, and it was relating to this case. And so in Chicago in 2007, there was a donor who had hepatitis C and HIV that was negative on serologic testing. So the tests were negative, and I'll come back to this when I talk about the testing we do, but certainly had high-risk social characteristics, classified as a high-risk donor. 4 recipients were infected with HIV and Hep C. 2 individuals passed away as a result of it. And then when they went back and looked at the sera and did more sensitive testing, which is nucleic acid testing, they actually found it was positive for HIV and Hep C. And so obviously a terrible outcome that really brought a lot of attention to this issue of donor-derived infections. These are the infections, as I said, that are reported now in a slightly more rigorous manner in the United States. This is the DTaC, which is it's a does DTAC stand for? It's the advisory committee in terms of actually capturing some of these infections. And so the number of donor reports between this 5-year period is higher than what I showed you in the previous 5-year period, so 320 total infections, a number of 131 recipients that had confirmed transmission, and then 36 deaths attributed to donor-derived infections. So it is a real thing that has to be considered. If we look at the types of infections that have generally been concerned, these are the issues. So in terms of bacterial transmission, it happens, I think, more often than we realize. And our policy in terms of bacterial infections is if someone has a bacterial infection as a deceased donor, that does not immediately rule them out as a donor. If we know what the organism is and the treatment has been initiated in the donor already, then we can utilize those because you can target the recipient right away with antibiotics, and then there's lots of data to say that's a safe way to go. But often if there's resistant bacteria, you don't have sensitivities, or it's unclear what the organism is, then obviously that's a very different situation, and we have to really think about the scenario there. Fungal infections obviously are much more dramatic clinically, really lots of morbidity and mortality associated with those, and they're much harder to treat. And so those are obviously big concerns, and if we have those concerns in donors, we don't utilize donors where we think that's a significant risk. Mycobacteria, the most common form of it being TB, is obviously something that we are concerned about with an evolving patient population that has increased exposure to TB risk factors. And so this is something, again, that we are very cognizant of, and again, we can initiate treatment in some of these circumstances, but it's an important one to consider. And then parasitic infections, again, very rare, and these are very hard to predict unless someone has an obvious infectious process that we don't know what's going on. It's hard to really dig into that kind of history with many of the deceased donors. And the one we tend to worry a lot about are viral infections, specifically HIV and Hep C. And so when we're thinking about these, based on these first few slides, you say, well, why do we even consider using these organs? Like, the easiest thing would be to just say, don't use anybody who's got any risk factors. And so clearly that is the priority, is to make sure, first and foremost, that patients have good, safe outcomes and have good outcomes. And so patient safety is always the overriding consideration here. But you have to balance that with the need to expand the pool of deceased organ donors. Even though I've showed you some great results in terms of what we've done in terms of deceased donation in this province and that our wait times are way better, we're still celebrating the fact that the mean wait time is still 2.5 to 3 years. That's not an insignificant period of time on dialysis that patients have to wait for transplantation. And don't forget, we're thinking about kidney, but organ donation also helps liver and heart transplants, where it's not so much life-prolonging. They may not have the alternative dialysis. You're looking at life-saving therapies. And so we have to balance both of those issues. This, again, is just to highlight that point, looking at what the demand is. So you've got the rates of end-stage renal disease on Canada on the left, on the top, and you've got rates of kidney transplantation. Transplant numbers are going up, but because ESRD rates are growing, our rates are actually not keeping pace with that. And so we still have a huge gap in terms of the demand and supply. Now, transplantation over time has gotten more complex, and in part that's resulted to a greater risk of donor-derived infections. And so if I alluded to this a bit in terms of donor characteristics, and so obviously we have a much more geographically diverse population in terms of background. So there's people that either travel, to many places around the world, or who were born in other countries, and so that does make it more complex in terms of risks like for TB and those kinds of issues. Antibiotic exposures, we've all heard on the news, and we see it work all the time. This is an issue, obviously. Antibiotic resistance is becoming a bigger concern, and that makes it a little more complicated to figure out what the best treatment is in some of these organisms. And then the longer people stay in hospital. So, it used to be that deceased donation was considered in a very small subset of people who were in hospital. And those are usually individuals that came in very quickly with either a traumatic head injury or a spontaneous neurological event. And then within a matter of a day or two, you knew they were donors. Now we have donation after cardiac death. These are patients that may have gone through a long hospitalization, been on a ventilator for a period of time that's quite protracted. And so you get more infectious complications with that may come up. We also are transplanting different types of patients, and so our management of recipients has changed. If you compare to many years ago, our overall intensity of immunosuppression is more intense. We're using heavier induction agents. We're more and more concerned about chronic rejection, and so we're actually implementing a bit more rigor in terms of ensuring immunosuppression. So that increases infectious risk in the recipient. In the cardiac world, you've got more devices that are in situ, so you've got LVADs and these kinds of things, which is where you can seed infections, so that's an issue. And then in terms of transplant programs, we're lucky in BC, we've got a provincial program, everything kind of happens at one place and it's very coordinated. But if you look at other provinces or other countries where you've actually got lots of different programs, you get lots of variability in terms of what people are willing to accept and not. And so that gets very complicated in terms of some of these decisions. So how do we deal with this? Well, to deal with donor characteristics, we've had to revamp the pre-donation screening process to assess for infectious risk. In terms of recipient characteristics, there has to be a rigorous process in place for post-donation monitoring, irrespective of risk factor to some extent, to just always keep a keen eye on what's happening in terms of potential donor-derived infections. And then, of course, in terms of transplant programs, for example, if we're transplanting patients that are from the interior in Vancouver, that communication piece, if there's concern of any infectious risk from the donor, is important, so that that's something that they can keep in mind when they're looking after the patients long term. So what do we actually do for donor testing? So this is our standard screening. So the first thing, as I said, is history. So we get as much information and collateral information as we can. The coordinators at BC Transplant do a lot of work trying to contact family physicians, trying to get a hold of the next of kin. They do a good job, but often, we're not going to be able to get the true story in many circumstances, so they do their best. So that is limited. And then there's laboratory results that we look at. And so serologic testing is done on everybody. Every deceased donor, potential deceased donor, has an HIV serologic test done to look for an antibody, a hepatitis B surface antigen, and a hepatitis B core antibody, a hep C antibody, syphilis serology, CMV and CMV is Cytomegalovirus and Epstein-Barr virus, which are important because those are transmissible infections, we know, just don't have the same level of consequence in terms of recipient outcomes, but we check for those. Toxoplasma cultures, all that stuff gets routinely done on all donors. And before we make a decision to proceed with donation and transplantation of those organs, we have to get the results for all these. There's also an additional series of tests that will be indicated by history. So not everybody gets these, but fungal infections, more unusual pathogens. For those, there is testing available. We have an infectious disease expert, Dr. Wright, who works with BCT and advises us on what additional testing needs to be done, but that's what happens there. And then probably the most important thing that we have, which is a second layer test, is the nucleic acid testing. When I showed you that case in the New York Times from Chicago, when they went back and saw the HIV cases that were transmitted, if they had done this NAT testing, you would have caught those and you wouldn't have transplanted those organs. And so that is now routine second level testing for high-risk patients. So even though that process exists, obviously it's still challenging, right? So the history, as I've said a couple times here, is very unreliable. And this is important when we're talking to patients as well, for them to understand that, our ability to get a consistent history for any deceased donor is going to be limited, right? So you may have one donor may have a family member who knows the detailed history, and someone else, you may have very limited next of kin, or even if you do have next of kin, they may not be aware. So you always have to take the history with a bit of grain of salt. But that is something that we have to be aware of. Serologies are the gold standard test to look at here, but you have to think about what's going to impact those results. So if someone's got massive blood products, that can throw off those results. And the most important thing is when the exposure happened. So serologic tests are good at picking up exposures as long as they happened a little while ago. If someone was exposed in the last couple of weeks, your serologic test might not pick it up. And that's the scenario where you need to really be thinking about the more sensitive tests like the NAT testing. And then there's real life healthcare stuff. There's the costs and logistics of facilitating this between Friday at 5 p.m. and Monday morning, when often this stuff happens, and you're trying to get these tests done and coordinated in a fashion that we can get these results. Now, on the recipient side, there's also a number of challenges of actually picking up. So if there's nothing that was obvious in the donor, if we haven't seen anything clear in the donor, we're not, although we're thinking about it, it may not be at the forefront of your mind to think about this when your recipient's unwell. Also, we have immunosuppressed patients, and so when patients are on immunosuppression, you often don't get your classic presentation of an infectious disease. It might be slightly muted, it might be an atypical presentation, and so you have to be really rigorous in terms of keeping an eye on what's happening on the recipient side. And then there is an issue of emerging infections. There's an issue of more resistant infections, and often this is challenging for us to move forward. So let's go back to a couple of those case scenarios. So this was the first one. Here I corrected this in the PowerPoint. So this is the 44-year-old man who was in prison and was released 8 months ago. Good kidney function, no known drug use or high-risk sexual behavior. This was the second case, which was the 24-year-old man who had a drug overdose and has a history of IV drug use in the last 2 weeks. And so the question is I guess, let me go back. So for case one, how many people think this person would be a high-risk donor? Okay. How many people think this is definitely not a high-risk donor? Okay. And how about for this one? How many people think this is a high-risk donor? Yeah. So I'd agree, that's a high-risk donor. So what constitutes high risk? And so there are criteria. This is the Canadian Standards Committee with Health Canada has laid out these, and these are very similar to what happens in other countries. There's similar lists of what's considered a high-risk donor in the U.S. And I'll go through these because these are important. And it's important to understand that there's quite a degree of variability in what we're calling high risk. So non-medical IV, IM, or subcutaneous injection of drugs in the preceding 5 years, that's considered high risk. Men who have had sex with another man in the preceding 5 years, that's considered high risk. Patients who have engaged in sex in exchange for money or drugs in the preceding 5 years, so commercial sex workers or patients who have actually paid for sex. Persons who have had sex in the preceding 12 months with any of the above persons or person known or suspected to have HIV, Hep C, or Hep B. So you can get the sense that some of this is hard to get with collateral history if you're talking to someone's wife. Exposure in the preceding 12 months through percutaneous inoculation or open wound, prison, lockup, jail, or juvenile detention of greater than 72 hours in the past 12 months, non-sterile tattooing, piercings in the past 12 months, close contact with anyone with clinically active viral hepatitis, specifically living in the same house where a kitchen and bathroom are shared in the past 12 months. Pragmatically, another thing we often add is if we know we can't get a good history, if we can't get a reliable sexual history, then that gets added to this list as well. So what are the actual risks in some of these scenarios? So you can see there's a pretty broad risk of scenarios. And it also, some of these issues, even though if we deem these donors to be medically safe, we have to be very cognizant of patient perception. Often on the transplant side, we underestimate the psychological impact of receiving a deceased donor kidney. There's feelings of guilt, there's feelings of confusion, there's lots of stuff that recipients are going through. And when you add this extra layer of, oh, by the way, this person had this social risk factor, we're thinking about it from a very black and white perspective. What's the risk of transmitting an infection? But for a patient who's hearing it, there may be many other connotations with some of these issues. And so we have to be sensitive to that. So I don't routinely, in the name of confidentiality, tell patients what the risk factor is. We'll say this person has a risk factor, and then we'll tell them what the risks of transmission are. But we don't necessarily go through the specific details of it. So this is what the actual risks of individuals in some of these risk categories, of them actually having some of these infections. So for an IV drug user, if you look at the incident rates, so prevalence of HIV is about 18%, Hep C 38%, but in terms of the incident rate, it's about 2. Men who have sex with men, you've got a 25% prevalence of HIV and a 4% prevalence of Hep C. Commercial sex workers have the highest rates in terms of 24 for HIV and the highest incident rates that they have. And inmates have rates, as you can see there. So there's a bit of variability there. So what do we do? So as I said, the first standard of care is to do serologic testing, and they will rule out most infected donors. So we're worried really about the false positives, right? We don't want to say someone, false negatives. We don't want to say someone has a negative test and then in fact they do have this. And so the window period really it boils down to is when was their high risk exposure and when are we doing this test? And so for HIV, if you have a negative serological test, you can confidently say that that person does not have HIV as long as they weren't exposed in the previous 20 days or so. For Hep C, you can confidently say that they don't have Hep C if they haven't been exposed in the last 70 days, which is quite a period of time. For Hep B, it's about 40 days. And so you can see those windows are pretty broad. And so when we have someone who's been engaging potentially in drug use in the last month, this doesn't necessarily help you in terms of Hep C. Now, if we do the NAT testing, now this is PCR testing, it's nucleic acid testing that actually gets the viral load right away. Those windows narrow down substantially. So for HIV, if we have a negative NAT test, we can say that unless the person was exposed within the last 5 to 6 days, they're negative. For Hep C, that window is even narrower, it's 3 to 5 days. And for Hep B, it's still about 20 to 22 days, but it's shorter than the 40 days of serology. And so NAT testing is certainly indicated in high-risk recipients. It improves detection of Hep C and HIV, and it should be utilized in anybody that's got high-risk or questionable characteristics. And so the advantages of this obviously are it's going to reduce donor-derived infections and transmission. It also allows us to use organs a bit more willingly. There was surveys done in the U.S. where, in the absence of NAT testing, many centers weren't willing to accept deceased donors, and this has now become the standard of care. It also helps with public perception to know that we are actually using the best available test to rule out infectious diseases, and that, as we should be. Now, what are the disadvantages of it? Because you may ask, well, why don't we just do this in everybody? Why only in high-risk individuals? And what it boils down to is the false positive rate. So there is a false positive, a significant false positive rate. So in an average risk donor, there'll be 76 false positive donors identified for one true positive for HIV and 45 false positives for one with Hep C. So they're not huge, but there are sizable enough that if we did this across the board, we'd probably be turning down donors that we didn't need to. And so you kind of go with, like anything we do in medicine, what's the pretest probability of this, and then we go ahead and implement the test for this. So that's the rationale. Now, there is improvement on these tests, and I think in the not too distant future we're going to be in a point where these false positive rates are low enough that we probably will be doing this across the board, but we're not there yet. The other issue, as I alluded to earlier, is the logistic issues around getting it done. So this was a while ago now, in 2010, there was a consensus conference where essentially it was decided that, there's insufficient evidence, as I said, to do this as standard of care for all deceased donors, but we should really do this specifically for HIV and Hep C and potentially for Hep B as well. I'll tell you what we do in BC. So we do everybody gets the screen, everybody gets serologic testing. If anybody has anything on that list that I showed you that's high risk, they automatically get NAT testing for HIV and Hep C. If there's a questionable history, they get NAT testing. So the threshold to do NAT testing is pretty low, although we're not doing it across the board. If there's a donor where there's clearly no history, there's no questions or concerns, we don't do NAT testing in those circumstances. For living donors, all living donors actually get HIV and Hep C NAT testing done prior to living donation in a shortened window before donation. And that's, I think it's a bit different because you have a much more reliable history there, and so you can actually really understand, and you have the opportunity of time to say, well, let's repeat it if it's a false positive, and you can get some interpretation around that. So that's what we do for living donation. Now, we focused on HIV and Hep C, but not Hep B, and so Hep B is a little different, right? So people who have had previous exposures, or Hep B core antibody positive patients who have been exposed to hepatitis B in the past, have cleared it, the risk of transmission is very low. People who have active hepatitis B, there's a high risk of transmission that does result in inferior outcomes, and so that is a consideration. But the plan really is all of our patients get immunized for hepatitis B. And so if we have to ensure that there's serologic evidence of adequate immunity in those patients if we're concerned about risks. And then we have a mechanism of prophylaxis, of either prophylacting these patients or screening them. And we tend to just screen them unless the risk is really exceedingly high. But that's why we don't automatically jump to the NAT testing for Hep B. It's available for circumstances where we need it, but generally speaking, we don't need it in that case. So I've told you what the incidence is of having infections in the different risk groups, but I haven't told you what the risk of transmission really is. So if we have a negative serology in a high-risk donor, like the 2 cases I presented, and we have negative NAT testing, well, what's the actual risk of transmission to recipients? And so these are the numbers that we have on that, and these are the numbers that we quote to patients. So again, it's broken down by risk category, but if we focus on the second line there, which is your high-risk group, really, it's your IV drug users. So if you have negative NAT testing in an IV drug user, then that person, the risk of transmitting HIV to the recipient is roughly 1 in 4,000. So it's a very low risk in terms of your risk of transmission. As you can see, if it's sex with a partner and above the categories, you're looking at 1 in 33,000. If it's someone who's incarcerated, like the first case I had, that's 1 in 25,000 if you have negative NAT testing. And so very, very low risks. If we look at Hep C, the risks are a bit higher. So if you look at IV drug use, which is the second line again, your risk of transmission in the setting of a negative NAT test is still 1 in 245, which is a lot higher than the 1 in 4,000. And obviously it varies depending on the different risks there. But as as many of you realize, the treatment for hepatitis C has evolved quite dramatically in the last number of years so that it's essentially curable. And so you've got 95% plus cure rates for patients who've got hepatitis C. And so if we modify that number a little bit and kind of say, okay, here's our base risk in the first row there, the first column, pardon me, and then you look at the fact that if that person gets something and you factor in a 95% cure rate, which is pretty standard in terms of the studies that have been done in this, then really what we're talking about is what is the chance of long-term harm as a result of Hep C for this patient. And those numbers now drop down in the IV drug user to about 1 in 5,000. So because treatment exists for hepatitis C, that has really changed the landscape in terms of hepatitis C risk. And so the focus is much more on HIV than it is on hepatitis C right now in terms of infectious risks. Now, when we're thinking about all of these risks, it's easy to get kind of caught up and bogged down in the different risks. And so you always have to benchmark it to the alternative. And the alternative is not getting a transplant or staying on dialysis for a longer period of time. And we have to remember that that is not an innocuous intervention. So staying on dialysis, waiting longer for your transplant is associated with increased morbidity, increased mortality. This is looking at Canadian data, just looking at patient survival in dialysis in different age groups. And so you have to factor all this in. If you have a young patient, you got 5-year survival of around 89%. But if you've got someone in their 60s and 70s, you're looking at a 25 to 30% 5-year survival. So you have to balance all those factors in. You also have to balance the fact that that we're always going to be limited in terms of our ability to get this history. So unless you have a live donor who you can truly vouch for in terms of their social risk factors, every deceased donor, there's risks that you have to consider. And so that's what we typically tell our patients. So then the question boils down to is when we have these high-risk organs, who should we really offer them to and how? And so, the who's a tougher question. Should it be to everybody? Should it be to only consenting individuals? Should it only be for a subset of patients who we think are super high risk and they're really desperate and they've got a high risk of mortality if they don't get a transplant, and those are the ones we should be offering to? Well, there's a number of different options and opinions on that, but the major considerations really boil down to, in my mind, is that number one, we need to communicate that risk to the patient. It is the patient's decision at the end of the day if they want to accept or decline these kinds of organs. And so Health Canada mandates that if any donor has one of those high-risk characteristics, we have to present that to the recipient. We have to present the risks that I just showed you, and then we have to let them opt in or opt out of that. We also need to ensure that there's an informed consent process when they say yes. That has to be properly documented. And then we have to make sure there's a rigorous surveillance plan for patients that have accepted so that we can follow up and capture any disease early. Now, in terms of how we communicate this, when this was not happening very often, often the conversation would happen when we're called the recipient in and say, "It's Dr. Gill calling, we've got a kidney for you." And the patient kind of goes frantic and you say, okay, you got to come here, you got to drive here, you got to be here in a few hours, we're going to do a bunch of tests, and also I got to talk to you about the donor. The donor had some high-risk characteristics, these are the risks, and you're having this conversation over the phone. That is clearly not a proper informed consent process through which we can actually do this. So that's modified now, and what happens now is at the time that we activate a patient onto the deceased donor list, there's a full conversation that we have with patients about everything here. We give them a document to take home that outlines these risks, and they pre-consent to wanting to hear about these offers. If they're not sure, they can still say, I want to hear about it, but at least they have some context going into it. And that's really what this, like anything we do in transplantation or in medicine, is really boils down to informed consent in terms of, so they understand the risks, they understand the context. And we're trying more and more to make sure that patients are having those conversations early, as opposed to at the 11th hour when they're caught up in the emotion of having to come and get a kidney. Now, in terms of the follow-up plan, this is what standard recommendations are for post-transplant follow-up. So everybody will get, at 1 and 3 months post-transplant, HIV and Hep C NAT testing will be done, as well as Hep B will be tested. And then at 12 months post-transplant, we do serological tests, because you're well beyond that issue now, that timeline where you're worried about the window period for the exposure, you're 12 months post. And so this is the standard testing that we do on all our patients. Now, if we kind of push the envelope forward, I talked about how the landscape for hepatitis C has changed a lot. So where the conversation in the donation and transplantation community is going now is, well, we do have treatments for hepatitis C. And we do have donors that come forward that we know are hepatitis C positive by serology. And can we utilize those organs? And there's data that's from a number of years ago, this is from 2003, looking that if you give kidneys from hepatitis C positive donors to hepatitis C positive recipients, you get pretty good outcomes. It's pretty equivalent outcomes as you would if you didn't give them Hep C, because most of the outcomes can be related to the recipient's Hep C status. They already have it. And so that has been the standard. That has been the standard, that if we have a hepatitis C positive donor that has serology positive, we would then say we're only going to offer those to Hep C positive recipients. The challenge is that there are not a lot of Hep C positive candidates on the list. And so often we are sending those organs out of the province. And often there's no one in the country that utilizes them, so those organs just don't get utilized. And so in an era now where we actually have treatments for hepatitis C, the question has certainly come up to say, well, can we allocate these to some patients who don't have hepatitis C? And if so, who are those individuals? And so the first thing you have to do is kind of break that Hep C positive group into a couple different subgroups. And so you've got patients that have serologically positive Hep C, but I've told you a lot about this NAT testing, which is a much more sensitive test and essentially looks at how much active virus you actually have in your system now. And so in the context of Hep C right now, serologic positivity for Hep C is pretty meaningless. It really boils down to what the viral load is. And so if you're Hep C positive, really what we want to know is, are you NAT positive? Do you have active virus, or do you not have active virus? And there's been a number of patients like that now. And so the question then comes down to, so if we have serology positive, but they're NAT negative, can we use those organs in anybody? So they don't have active virus, but they've remotely had Hep C at some point that they've cleared now. And there has been studies to say, in fact, that there's good evidence that you actually get eradication of Hep C if you don't have the viral load, and so it's safe to do so. So what we're actually doing, and what everyone's doing right now, and what's become standard is that hepatitis C serology positive patients who have negative viral loads, that means they have no active virus, they can be allocated to everybody. And that's become standard of care, and that's something we're doing as well. Now, if we push that a little further, the question now comes, well, okay, well, now what if you've got serology positive, but what about the NAT positive Hep C patients? So they've actually got active virus. I've just been telling you that we've got these great treatments, so can't we just give those to anyone as well? Why are we throwing those organs away? And that's where it gets a little trickier. Now, these are the treatments, and so you have to kind of say, well, how good are these treatments, and what's the implications of them, and how difficult is it for patients to take? So it's a 12-week course of therapy. It's oral therapy, and you get 95% plus cure rates, and so that's a very compelling argument to say, can we just give these to others? The other question that always comes up is people say, well, can we ethically do this? Can we actually take someone who we know there's going to be transmission? If someone's NAT positive Hep C, they've got viral load, it's 100% transmission. You're going to give virus to the recipient, no question. So is that ethical? And do we have any other paradigms where we do this? And then we have to step back and say, well, yes, we already do this. When I showed you the list of infections, we have Cytomegalovirus, which is a common virus that exists in the community. Many of us have been exposed to it. And if a donor is Cytomegalovirus negative or CMV negative, and if the recipient is CMV negative, that we still give them kidneys from donors who are CMV positive. So we're basically very high risk of transmission of that infection right there. How do we deal with those people? Well, we prophylax them with antiviral medications. We give them valganciclovir for 6 months, and we try to do that. So the premise of saying we will accept transmission knowingly of a virus as long as we have a treatment in place that we can mitigate the risk of that exists. And so from an ethical perspective, this is something that we can consider. There has been a trial of this. There's been a lung trial, but there's also been a kidney trial. So this is a small trial of 10 patients that were NAT-positive kidneys were transplanted to Hep C negative recipients. They treated all of them immediately, prophylactically, for a 12-week period. This is the time to essentially what happened to their viral loads. And so you can see each of these lines represents one patient. They all started with varying levels of virus when they first had their transplant, and within 30 days with treatment, virus was gone in all of them. Now, they've since published 12-month outcomes among these individuals and shown that actually that the virus didn't come back. It was curative in everybody. They looked at kidney function. They looked at GFR and creatinine levels. And all of those were very favorable and not very different to when they compared them to matched cohorts of individuals that did not get a Hep C positive donor kidney. So the outcomes, from an outcomes perspective, it seems reasonable. These are the types of patients they gave them to. So the mean age was 56 years. It was cause of end-stage kidney disease was pretty representative of what we typically see. In terms of the PRA, most of them were non-sensitized patients. Their median dialysis exposure was about 350 days, so about a year. And so you can see it's actually a pretty roughly equivalent group of people that we have on our wait list. So it wasn't really a selected cohort of individuals. And so if we wrap our head around the idea that we could use these organs, again, the question boils down to who should we give them to? Should we just give them to the person at the top of the list and go from there? Or should there be a special list of recipients? For example, someone who might be Hep C negative, but they're highly sensitized, or they're very sick, or there's some rationale where you'd say, it's still in an early phase, and if we're going to actually do this, should we be moving forward and only allocating it to those individuals? This was an interesting study that was done by the same group where they surveyed patients to say how do they feel about this in terms of accepting these organs. And so essentially they found that over 80% of recipients would accept a Hep C positive kidney under certain circumstances. And so a lot of it had to do with you knew the testing was negative, you knew that you would be treated, you could get availability. And so, there seems that from a patient perspective, there's not a huge reason to not consider this. Obviously, it's going to follow the same paradigm that we do for any high infectious risk donor where you get patient consent around this process. But it does seem like it passes kind of the first test to say this is a reasonable thing to do. The major challenge in implementing this, quite frankly, has been funding. The ability to get the medications for the Hep C treatment to be funded prophylactically for the recipients, because that doesn't exist. And so that's really where many places have been hung up. As a community, infectious disease specialists and transplant doctors and have all bought into this idea that this is a reasonable thing to do, but that's where it's been hung up. Now, in terms of what's happening in BC, there is a pilot that's being worked on right now to do this for kidneys at this time, something that will ultimately be expanded to other organs, but we're starting with kidneys, where we're going to setting up a set of criteria, and Matt Caddis walked in the back of the room. Matt's been leading that and doing some cost studies to convince the government that it's worth and very cost effective to use a few extra organs if the drugs are paid for hepatitis C treatment. And so all that is going to be coming up shortly. The details are still being sorted out in terms of how it's going to be rolled out and in which patients it's going to be allocated. That's still being sorted. But that just so you're aware, there will be communication around that obviously once that gets going, but that's something that's moving. So to summarize, and increased infectious risk donors are obviously in part contributing to our increase in donation, but and really this all boils down to how well we test patients and how much time we spend in communicating the risks and ensuring adequate follow-up in these patients. So I'll end there and leave some time for questions. Didn't leave as much as I wanted, but we got a bit.
No, that's great, Jack. Okay. Thank you very much. Okay. Okay, so we have one question here, Jack, if you can just read the question here.
Sure.
If anyone wants to ask questions here, I'll run the mic to you as well.
So the question is, TB may be a growing concern. One of my kidney pancreas transplant patients acquired TB, disseminated with multi-organ involvement from the donor. How are we screening deceased donors for TB? So everybody gets, obviously, the history in terms of that. The challenge with TB screening in deceased donors is timing. So it's tested, but you may not get your result back in time because you can't necessarily wait that long. So the IGRA test is what we would do, but it's going to take time to get that. And so often you go by history, but if there's any history that's questionable, we may initiate treatment anyways in consultation with infectious diseases until we get that result back. So that's how we typically tend to treat them. Other questions, comments? Thanks.
Jack, I had a question as well.
Yeah.
Are you aware of any studies that they give the antiviral treatments like Hep C treatments to the donor before the kidneys are being retrieved to try to reduce the burden of viremia prior to being allocated? Yeah,
it's a good question. I mean, I think, I can't think off the top of my head, James, if there's many. I can't recall. If there might have been a few cases where that's been attempted. I think the premise has usually been, do you have enough time again, right? So if you're going to need a 3-month course of therapy, then it might be you're not going to be able to pull that off. But you do bring up a good point, right? One of the major challenges that have come up in terms of considering Hep C positive donors is that have they received some treatment at some point in the past? And you're worried about resistance. So if someone's been treated in the past and they've still got active virus, well, that's something that we need to shore up and figure out. So we've been working on strategies to figure out that we actually know that information. And the treatments, the studies that have looked at what treatments they've initiated have been, they're purposely using agents that are good for resistant organisms as well, so they've got pretty broad coverage. Let me just read it, James.
So there's a question here. Are children considered, you get in the call, so.
Yeah.
Are children considered for high-risk donations also, or just for adults?
As recipients,
Yes.
No, everybody's considered. That anecdotally, often, the data would suggest that we shouldn't not offer these, because you have to remember that if you think of the overdose scenario, you're dealing with, unfortunately, young individuals that made a bad decision, and so you've got no really much in the way of medical history, and so from a kidney function perspective and how long that kidney is going to last, they're actually quite ideal for kids. So technically, yes, they are offered for children as well.
Okay, one more question. What is the cost of Hep C medications?
What is
the cost for Hep C?
The cost, Matt's in the back. Matt, do you remember what the rough cost is per course of therapy?
Oh, thanks, James. The market value for these drugs ranges, depending on the regimen, between $40,000 and $100,000 for a 12-week treatment course. But again, the discount that the government's negotiated with the pharmaceutical companies is probably around 50%, is what we estimate. We don't know. So that number is going to drop substantially. So you're looking between $20,000 and $50,000. And again, it's going to depend a little bit on the regimen and also whether or not there's any resistance, because if there is resistance to the hepatitis C virus, then we need to add in agents, which is going to increase the cost. But on average, you're looking somewhere between probably $40,000 and $60,000, depending on the genotype and the treatment regimen.
Now, for those of you who don't know Matt Kadetz is a postdoc with us, will be joining us as one of our transplant nephrologists soon. Matt does research in health economics, and so he, as part of the pitch to do this with BCT, has been working with Jag Gill and did an extensive cost effectiveness analysis, because these are expensive drugs. And it was 1 year essentially. If you shave 1 year off of dialysis, you've essentially recouped your costs in terms of this. And so that's the premise from the health government's, from the health ministry's perspective in terms of cost savings. You don't have to transplant a lot of people or save a lot of time off of dialysis before you start to see a fiscal benefit.
Okay, so a couple more questions here.
Sure.
So if a donor is deemed to be high risk and needs NAT testing, when is the testing performed in relation to donor admission to the hospital to ensure that a sufficient amount of time has passed for the testing to be accurate?
Yeah, it's a very good question. So it's tricky because the number one factor in deciding timing of interventions or testing and time of donation really is what the donor family wants. And so if you have the luxury of time to wait, then you will, but typically we don't mandate that you have to wait those window periods, because even if you're within that window period, the risks of the transmission that I showed you are low enough that you're good. Now, if one of those cases I showed you, the patient was in hospital for a week, those risks of transmission go down to essentially nil if you're not within that window period. And so the NAT testing, you're not going to get a lot of false negatives outside of that window period, but we don't mandate a time.
Okay, another one is what is the cost of Hep C treatment compared to prophylaxis Valgan for CMV?
Well, Valgan's much cheaper than cost of Hep C, but I think it's analogous in the sense that it's analogous in theory, right? That we are essentially knowingly potentially infecting recipients for the purposes of transplantation, but in terms of costs, it's very different, right? But you could also argue that from a curative perspective, the data on Hep C cure is much more compelling than it is for CMV. We struggle with CMV among patients that are CMV positive from their own latent infection, and then they get reinfection, and we have lots of complications that we have. So I think from a long-term risk perspective, actually, the Hep C might not be as significant.
Okay, I think that's
Good.
it.
Thanks,
Thank you very
everyone.
much.